Okay, so a very good evening, students. Let me check whether I am audible or not. Yes, yes, I presume I am audible now. Okay, so let me take my pen. So, a very good evening, students. So, today, as I said, and we'll be taking important MCQs on recent advances. And as you know, in our subject, community medicine, we have to also deal with the recent advances also. So, this is also one of the many sessions which I have taken. So, this is also on recent advances. So let's try to take certain questions on recent advances, and so that we are updated, and this definitely makes us to understand the evolution and the overall development which take place uh, around the subject. Okay, now, so I can see many people have joined. Okay, great. So let's start. Good evening, Sonam. So let's take the first question, and the first question, as we know, we are in the cloud, we are in going on through this unprecedented pandemic COVID. So let's take one question on COVID first to start with. The first question is, students, rapid antigen test. You must have heard about rapid antigen test. It is going on. So rapid antigen test in COVID is recommended for. Is it recommended for all symptomatic influenza-like illness? It is recommended for asymptomatic direct and high-risk contacts with comorbidity of a confirmed case to be tested once between day 5 and day 10, or all asymptomatic ILI patients presenting in a healthcare setting and are suspected of having COVID-19, asymptomatic patients undergoing aerosol generating surgical, non-surgical interventions, and all of the above. So what do you think, students? What is the guideline by the government of India uh, as far as rapid antigen test in COVID is concerned? So the gold standard test happens to be RT-PCR, but nowadays we are going with rapid antigen test also. So is rapid antigen test for COVID is recommended for what? Is it A? Is it B? Cyan is going with E. Okay. Anyone else? Anyone else? Others? Everyone should try, students. Just try. I can see Cyan has answered E. So rapid antigen test is recommended for. Sonam also goes with E. Anyone else? Okay. Now, why this question is important, students? Because as you know, the gold standard test happens to be RT-PCR. Now, now the government, because we have huge case loads, everyone, Rakesh, Sumit, Sonam, Sayan, everyone has answered E. Okay, so the answer is correct. So all of the options are correct. So all these options they can undergo rapid antigen test. Now, what is important for us to know about rapid antigen test is, students, first of all, it is the first the antigen test which is used now, which is generally used, is developed by SD Biosensor, a company of South Korea, and it is basically manufacturing unit is in Gurugram. So we are not interested with that. Now this test can be interpreted as positive or negative after 15 minutes. Okay, so by 30 minutes we'll be getting our results, at max 30 minutes. So the test kit has to be stored between 2 to 38 degrees Celsius. So this is the initial information which I wanted to share. Now, what are the criteria for antigen test? Criteria which the question was asking: all symptomatic ILI, all person having having influenza like illness, so they can undergo antigen test. All asymptomatic direct and high risk contacts with comorbidity also of a confirmed case can go for antigen test between day 5 and day 10. All symptomatic ILI patient presenting in a healthcare setting and are suspected of having COVID-19 infection, they can also go for antigen test. Asymptomatic patients who are hospitalized or seeking hospitalization falls under high risk group, they can also go for antigen test. And all asymptomatic patients undergoing surgical and non-surgical interventions should also go for antigen test. So antigen tests, these are the criteria for which antigen test should be done. Now, how do you interpret antigen test? The most important thing is, if an antigen test gives you a positive result, no, says that you are positive, it means that you are positive with COVID-19. So means we don't need to go for RT-PCR. If it is negative, we also don't go for RT-PCR. But there is a clause, and there is a clause is, if a symptomatic patient, when I say symptomatic, he is having influenza-like illness, he is symptomatic, and he has undergone an antigen test, and the antigen test is saying negative, just to cross-check, we go for such patient for RT-PCR to rule out infection. This is the only thing, student, you should remember. Antigen test saying positive, you are positive. Antigen test saying negative, you are negative, provided you are asymptomatic. If you are symptomatic and then the antigen test is saying negative, then to rule out whether I am suffering from COVID infection or not, we'll be going for RT-PCR. This is the thing which you have to always remember with antigen test. Positive, you are positive, no need to go for RT-PCR. Negative, asymptomatic, no need to go for RT-PCR. But you are negative, but you are symptomatic, just to rule out whether you are positive or negative, we go for RT-PCR. Okay? Okay, the next question. With a significant increase in access to state-supported healthcare, the out-of-pocket expenditure as a percentage of total health expenditure has declined to -% in 2016 and 17. This is the most recent change, students, which you should know. It is 57.7%. Is it 58.8%? It is 59.9%. It is 64.2%. The question is saying, with support of state, as health is a state subject, the out-of-pocket expenditure as a percentage of total health expenditure has declined to what percent in 2016 and 17? Is it 57.57? It is 58.8. It is 59.9. It is 64.2. Anyone? Dr. Himani, Sumit, Rakesh, Prachi, Sayan, Sumit, anyone? Sonam? Just try. Okay. Okay, so let's go. Okay, Sumit is going with D, 64.2. Anyone else? Monica going with B. Okay. Monica goes with B. Okay. So, okay, everyone going A, C. So we have mixed responses, no? Now, the answer which Monica has said is correct. It is 58.8%. Students, those who have not answered B, it doesn't mean that they are, because this is very recent change and it's not possible for all of us to be acquainted with this. So I thought I should share this with you. The answer is 58.8. Now, what does this mean? Now try to understand this. This is from the latest 2020 June document from NITI Aayog. So NITI Aayog basically has released a document on different goals of SDG, where India is, how India is performing as far as SDG goals are concerned. So in that document, which has been released in June, in that document it says that with the support of healthcare, state healthcare, the out-of-pocket expenditure has reduced, has declined, please remember, has declined from 64.2%, which was in 2013 and 14, to 58.7 to 58.8%. So 64.2, it has come down to 58.7%. So this is a very, as a recent, so out-of-pocket expenditure has come down. How it has come down? There are, in addition to the already running programs, we had Pradhan Mantri Jan Aushadhi Pariyojana, where the quality medicines were supplied at an affordable price. So when the quality medicines were provided at an affordable price, so out-of-pocket expenditure has gone down. Second, we have a free drug and free diagnostic services program also, where free drug and free diagnostic services is provided at the PHC, CHC and district hospital. So with both this program, where the quality medicines are provided at an affordable price and the free drug and diagnostic services, both this program has reduced the out-of-pocket expenditure from 64.2 to 58.7%. Please remember, this is the recent numbers which has been released by Government of India. Okay, very right. Pankaj has also answered correctly. Good, very good. Now, India's doctor population ratio is what? What is India's doctors population ratio? If you have to quote one data, which data you will quote now? Is it 1:1700? Is it 1:1456? Is it 1:1000? Or is it none? Just try, students. What is the India's doctor population as of today? If somebody has to say, okay, Arjun is saying B. Okay, anyone else? Okay, Rakesh is saying C. Others are also saying C. Okay. Now, yeah, C. Yeah. Okay. Now, the answer to this question is 1:1456. So Arjun was absolutely correct. 1:1456. Now, students, why? Just see this status of India as per NITI Aayog report 2020. So the NITI Aayog report has published a data, has a document where it says that doctor population ratio is 1:1456 against WHO benchmark 1:1000. Yes, Sumit is right. So for every 1000 population, we should have one doctor. But in India, it is far behind. We are, for every 1456 population, we have one doctor. But definitely the conditions, if you compare from the past, it is gradually improving. So as of now, if somebody asks, please quote this 1:1456 number. This is the current number which has been released by the Government of India. I am saying, yes, Sumit, but I am saying this is the June report, June 2020 report. This is the change I am telling. This is the change I am telling. I know that what I know it is what when you say 1456, people will not believe. But the document says, the recent document which has been released by Government of India says 1:1456. Okay. Now you see this question. This question, just first take it, then I'll tell you the history of this question. In order to address dual morbidity of tuberculosis and COVID-19, following activities should be carried out. Bi-directional TB-COVID screening, TB screening for ILI cases, TB screening for SARI cases, all of the above. Just try this. In order to address dual morbidity of tuberculosis and COVID-19, following activities should be carried. You want bidirectional TB-COVID screening, You want TB screening for ILI cases, you want TB screening for SARI, you want all of the above. So Arjun goes with A. Anyone else? Dr. Himani goes with D. Yes. Try others also, try students. Monica goes with A. Okay. So Patel goes with B, A, D, all the means yes. Now you know the answer to this question is D. Answer to this question is D, all of the above. Now what is the background of this? Today, what is the date, student? Today we have 28th August, no? So on 26th August, I am saying 2 days before, 26th August, as one of the steps, one of the many steps which Government of India has taken, they have also come with a guideline on tuberculosis and COVID. Now this is important because respiratory tract is involved both in COVID and TB also. So they have come with this, that all patients, either COVID or TB, what should be done. So we should do bi-directional TB-COVID screening. I'll tell you what is that. Let's screen all ILI cases. Let's screen all SARI cases. So answer to this question is all of the above. Now what you have to know, you see this now. COVID screening for diagnosed TB patients, right? So a diagnosed TB patients need to be tested for COVID. So a person who is diagnosed TB positive or is currently on TB treatment, we should go for testing for COVID also. If the person is COVID positive, then manage that COVID as per the guideline. If it is negative, then continue the TB treatment, not a problem. So this is one directional. So a TB patient is undergoing for COVID test. Positive, treat COVID, negative, continue TB. So this is one thing, one direction. Second direction is TB screening for COVID positive patients. So a COVID positive patient, all COVID positive patients should be screened for TB if they fall under 3 criteria. What are those 3 criteria? First is 4 symptom complex. Means a COVID positive patient is having cough for 2 weeks, persistent fever for 2 weeks, significant weight loss or night sweats, which is the common symptoms of TB. So if a COVID positive has also got these features. 1, if the COVID positive patient has a contact with the TB case, history of a contact with the TB case, or has a history of TB and symptomatic now, should go for chest X-ray and nucleic acid amplification test, which is CB-NAT or TrueNAT. So it becomes bi-directional. All TB patients are screened for COVID. All COVID positive patients can be screened for TB if they fall under these 3 criteria. First is 4 symptom complex, which I said, cough for 2 weeks, fever for 2 weeks, significant weight loss and night sweat, or history of contact with TB case or history of TB case and symptomatic. So they will also go for nucleic acid amplification test, CB-NAT or TrueNAT, for diagnosis of TB. So you see this becomes bi-directional. No? Now, so just to make it more simpler, a COVID positive patient screened for TB if they have those symptoms, 4 complex symptoms followed by history of contact with a TB case or history of TB. So they will go for CB-NAT and X-ray. If they are diagnosed positive, they will go for TB management also. Not diagnosed positive, okay, continue with COVID treatment, not a problem. So it becomes bi-directional. Third, all ILI cases, when I say influenza-like illness cases, should be screened for TB. We are already screening for COVID, we will also screen for TB. If you are screening for TB, you can get positive, you may not get positive. If you get positive, treat for as per TB guideline, you are not getting positive. If it is COVID positive, treat the COVID positive. All SARI cases will also undergo for screening of TB. So this is the new guideline which has been issued 2 days before. So now it becomes bi-directional screening, a TB patient going for COVID screening or COVID patient going for TB screening. All ILI patient going for TB screening, all SARI patient going for TB screening. So the answer was all of the above. Okay. Now, let's take the next question, students. A patient with acute respiratory illness, fever and at least one sign and symptom of respiratory disease, and a history of travel to a residence in a location reported community transmission of COVID-19 disease during the 14 days prior to symptom onset. What do you call it? You call it a suspect, you call it a probable, you call it a confirmed case, you call it a contact case. What do you call? So you have a respiratory symptoms followed by a history of travel during last 14 days. So what do you call that? Do you call it as a suspect case? Do you call it as a probable case? Do you call it as a confirmed case? Do you call it as a contact case? Suspect. Himani goes with suspect. Very good. Anyone else? Yes. Dr. Samir, Arjun, everyone going with a suspect. Yes. So you have a respiratory symptoms, travel history, travel history from area which is having community transmission. So let's go with the answer suspect. Okay. So if you see these 4 things, you all know this because we have talked and COVID. So this is suspect. Now what is probable? A suspect case, a probable case is a suspect case only, but the diagnostic means the diagnosis which has been done, the test which has been done, it is inconclusive, indeterminate. You are not able to say whether it is positive, negative, the test, sometimes it happens. So that, but it has got all the features of suspect, means it has got respiratory symptoms, has got a travel history, maybe has a travel history, but the test when you did, the result is inconclusive. So that those cases we keep it under probable case. Confirmed case means laboratory diagnosis has been done and it has been labeled positive, so it is a confirmed case. Contact case happens to be all those persons who comes in close contact with the confirmed TB case or confirmed COVID cases happens to be contact case. Okay, good. Now let's take the next one. Adolescents or adults with presence of clinical features of dyspnea or hypoxia, fever, cough, including SpO2 less than 94% on room air, respiratory air rate more or equal to 24 per minute. So such patients can be managed where? Can you manage at COVID care center? Can you manage at dedicated COVID health center? Can you manage at dedicated COVID hospital? Can you manage at private hospital? What is the guideline? What is the guideline? Government guideline says. So a person is an adolescent or an adult having features of fever, cough, dyspnea, SpO2 is less than 94%, respiratory rate is 24 or more. Where will you manage it? At a COVID care center, dedicated COVID health hospital, dedicated COVID health center, private hospital. Try, students. Himani goes with B. Jelena goes with C. Okay, others. Okay, C, B, C. So there is, we have B also, we have C also. Now, so the answer to this question is B. It is dedicated COVID health center. Now, how do you segregate this? Now, try to understand. Mild, very mild cases will go to COVID care center. Moderate sign and symptoms where you have respiratory rate between 15 to 30, SpO2 90 to 94%. This goes to dedicated COVID health center. And when the respiratory rate is greater than 30, SpO2 is less than 90, it goes to dedicated COVID hospital. And what is the difference between these two, students? Dedicated COVID health center has got all the features, but except ICU. You don't have ICU here. But in a dedicated COVID hospital, you have ICU. So this is for severe cases. Okay. So the mild cases can be managed at COVID care center. The moderate cases can be managed at the dedicated COVID health center, and the severe cases will be dedicated COVID hospital with ICU facility. One more addition, which last time which I discussed, mild cases can be treated at COVID care center. They are also eligible for home isolation. They are also eligible for home isolation. So just remember that if the treating medical officer thinks that this patient can be treated at home, if he has all the prerequisite which is required for home isolation, he can be treated at the home isolation, at the home. So he can be isolated at home. Okay. Now the next one, as per Poshan Abhiyan, goal to reduce stunting in children is. What is the goal of Poshan Abhiyan for reducing stunting in children? Is it 3% per annum? Is it 4% per annum? Is it 5% per annum? Is it 2% per annum? Just try this, students. As per Poshan Abhiyan, what is the goal to reduce stunting in children? Is it 3%? Is it 4%? Is it 5%? Is it 2%? Just try. 3%, 4%, 5%, 2%. Arjun, Sumit, Monica. Monica goes with A. Arjun goes with D. Okay. Others, Samir, Prachi, Samir goes with D. Yes. Now, so to answer to this question is, Poshan Abhiyan, the target or per annum reduction in stunting which has been kept is 2% per annum. So you are absolutely right, Samir. So it is 2% per annum. Please remember. So the government has thought to reduce 2% per annum is the stunting. Let's take the few more questions on this so that we know all these targets. We don't have to forget, and you can make a similarity with all this. So as per Poshan Abhiyan, again, goal to reduce undernutrition, means underweight prevalence in children. What is the goal to reduce undernutrition? Is it 3%, 4%, 5%, 2%? Again, student, the same thing. But this time not stunting, this is undernutrition. Come on. Patel, Jalina, Rakesh, Prachi, Samir, Arjun. Just try. Yes. Patel goes with 2. Absolutely correct. Anyone else? Okay. Arjun also goes with 2. Yes. So, stunting, the previous question, what was the goal? 2% per annum. Undernutrition, what is the goal? Because both are for children, 2% per annum. Please remember, so both the component, we have to reduce 2% per annum as per Poshan Abhiyan. Now let's take the third question on similar line. As per Poshan Abhiyan, goal to reduce low birth weight is. How will you reduce the low birth weight? What is the percentage? Try this. Is it 3%, 4%, 5%, 2%? So as per Poshan Abhiyan, what is the goal to reduce low birth weight? 3%, 4%, 5%, 2%. Try, students. Amani goes maybe D. Yes, go with D. Absolutely correct, Dr. Himani. Go with D. Now, 3 questions. Poshan Abhiyan, back to back. Answer was same, 2% per annum. So, it will help us to remember the Poshan Abhiyan says reduce stunting 2% per annum, reduce underweight 2% per annum, reduce low birth weight 2% per annum. So, we will not be wrong anytime if such questions come, because this is the recent thing. Now, take this now. As per Poshan Abhiyan, goal to reduce anemia. Now you are talking about anemia amongst children. In children, what is the goal for reducing anemia? Is it 3%? Is it 4%? Is it 5%? Is it 2%? Try this. Anemia. Anemia 3. Arjun is saying 3. Monica is going with B. Anyone else? So, what is the question? The question says, Patel goes with A. Yes. The question says, we want to reduce anemia. No, but the age group is children. So, before this question, there were 3 questions on stunting, underweight and low birth weight. All was 2% per annum. Now we are talking about anemia. So, in anemia students, keep 3% per annum. So, the government has envisaged will be reducing 3% per annum. Now, please make a link. Take the next question. As per Poshan Abhiyan, goal to reduce anemia amongst women and adolescent now. So, that was about children. What do you want as far as women and adolescent is concerned? How much do you want to reduce anemia per annum? Is it 3%, 4%, 5%, 2%? Subham goes with A, I presume. Samir goes with D. Okay. Now, this is with regard to, Mahesh goes with B, 4%. Okay. This is with regard to anemia, but the age group, but the target is women and adolescent. Students, this also you go with 3% per annum. Okay, 3% per annum. Now, see, 6 bullet points, 6 questions, and all it become easy for us to remember. Stunting, children, 2%. Undernutrition, children, 2%. Low birth weight, 2%. So this 2% per annum. Now what we are talking about anemia, it is 3% per annum. Now it becomes easy. You will never forget. You talk about stunting, you talk about low birth weight, you talk about underweight, 2%. You are talking about anemia, irrespective of children, adolescent, pregnant women, or women, 3% per annum should be the reduction target. Okay. Now let's take this one. Under 5 mortality rate of India is. What is the under 5 mortality rate of India? Easy one. What is the under 5 mortality rate of India as of now? Is it 36 per thousand? What Mahesh has answered B. Prachi B. Prachi is answering with D. Okay. Anyone else? Imani goes with D. No. Students, no. It is 36 per thousand live birth. The answer is B. No, answer is B. Now, what I'll do, students, try why we forget all this. There are 3 or 4 indicators. There are 3 or 4 indicators which normally we should remember. One is under 5 mortality, infant mortality, because anyone can ask this, neonatal mortality and maternal mortality ratio. Now what happens with this? So those who are answering 37, 35, what happens? Every year SRS data comes, so we have a updation, so it keeps on, it changes. Now, how do you keep a track on this so that you don't forget? This is important, no? So now I tell you 2018, I am saying we are in 2020, we have SRS data of 2018 which was published in May and June. Now 2020 SRS data which has come is of 2018 data. So till 2018, the latest under 5 mortality is 36. So you can question, you can say what was before? If I take 2017, it was 37. So from 37 we came to 36. If we talk about infant mortality, students, it was 33, we came to 32. And when I talk about neonatal mortality, it was 23, as of now also it is 23. When I talk about maternal mortality ratio, it has come down from 122 to 113. Now, you can say that how do you remember and how should we remember? If I know this one, which is the current now, 36, 32, 23, 130, and this number will stay for at least a year, because next year only we will have the 2019 data, for example. So 36, 32, 23, 113, if we keep on quoting on a regular basis, because this on and off people ask and you may be asked. So now 2019 data when it comes, so obviously under 5 mortality from 36, it will come down because there will be progress, or there will be progress. So from 36 it will come down to 35, 34, whatever. From 33 it came down to 32, so it will go down. So because we are progressing, with the health system is progressing, so your numbers will come down. So it is important to know such numbers so that the next number when it comes, it becomes easy. So you will say, okay, it was 36 in 2018, okay, 2019 data has come, so it has come down to 35, okay. So you correlate, you don't forget. You know it was 122 maternal mortality. Now July edition of SRS says it has come down from 122 to 130. Okay, it has come down from 122. So you know. So this is the way you remember, students, and you will not be wrong. Okay. So this is under 5 mortality, which is 36 per 1000 live birth. Okay. Now students, thank you for joining. I'll stop here. I hope this helps you. There were few recent things that bi-directional TB and COVID was 2 days before it has come. And when I was planning for this session, I thought why not share with the students so that they are also acquainted about TB and COVID, how this comorbidity is being addressed by Government of India. So definitely this will help you. With that note, students, thank you for joining. Take care. Bye-bye.